Hi there. My name is Paul Biondich. It's nice to be with you all today. I'm honored to be with you all and to help inaugurate the work that CHOP is doing around global health informatics. Just as a quick background about myself, I'm both a pediatrician and a geek, and so I might whip through things pretty quickly on a technical level. So we'll review some of this stuff on Q&A later, hopefully. But it might not surprise you when I say that I think that information is care, and I think that healthcare is essentially an information-centric business. And my work in global health actually got an inauspicious start in 2004 when I was asked to go to something called AMPATH, the academic model for providing access to healthcare, which was an academic partnership between my university, Indiana University, and a university in Kenya called Moi University. And supposedly I was going for a week as a consultant. I was reluctant to go. To be honest with you, I had never at the time gone farther from the US other than like Bermuda. And so it wasn't really clear to me how someone of my background was going to be helpful in that environment. For those of you who aren't aware, Eldoret is in the Western Kenya. And when I arrived there, I worked in the clinics for the first day. And this is a picture that we took during that trip. And what I saw was a rapidly growing HIV enterprise that was bursting from the scenes. But from an information system perspective, was completely overwhelmed as it was growing. And the system that I was asked to go and give some help around was, in fact, a Microsoft Access database. But at the same time, not only did I witness this, but I also witnessed a lot of really bright young Kenyans who were optimistic about what they could do to support information systems work. And I got kind of bitten by the global health bug, as many people do as they go and have these experiences. And so collectively, we agreed to work together and built what at the time was called the AMPATH medical record system. And the AMPATH medical record system was something that we worked on between the Kenyans and us in Indianapolis for the first couple of years. And it was ultimately switched on Valentine's Day, 2006. And it was turned on to support 12 clinics and about 20,000 patients. And the medical record system at the time was something very simple, very low tech. It was, in fact, a web application, but it was largely designed to enter in data from paper forms. And so we had a team of data enterers enter paper-based information and then transform that information into paper-based abstracts, which were summaries of a person's longitudinal HIV care. Extremely popular, but decidedly low tech because that's what the environment needed and that's what people had asked for. And so we worked to do what we could given the wherewithal that we had. And we ultimately started building additional functions where you could, for example, look at collections of patients through something called a cohort builder. Just as a quick anecdote, if you fast forward to today, that AMPATH system and the AMPATH model has grown unbelievably. It has over 63 clinics, and that record system is still operational today, has over 320,000 patients, 11 million encounters, and well over 400 million observations. So a very large system by any measure. As you can imagine, keeping a system like that operational and, more importantly, getting it more sophisticated as the clinical environment gets sophisticated becomes something really hard for an individual clinical environment to do. And so when we looked and saw what others were doing in that space around that time, what we saw were a bunch of silos, a bunch of different kinds of information system activities that were working independently of each other. It was a sea of access databases. And that changed when we met this guy, this handsome guy over in the bottom left corner. His name is Hamish Fraser. Hopefully some of you are familiar with him, but he worked at Partners in Health, a Boston-based philanthropy. And we showed him the work that we were doing. He recognized very similar pangs of what we were experiencing and said, well, maybe we could collaborate and work together on this work. And that ultimately came at the same time that we were starting to field some interest from some environments in Tanzania and Uganda. And we met this one guy in particular, a guy named Daniel Kaiwa, who probably even to this day, could code circles around most people from a place like the United States. A lot of really bright people were starting to converge around this project, and they really helped us understand that maybe the way that we could get to sophistication wasn't by doing it all of ourselves, but by building a collaboration across various different stakeholders that were interested in this work. And that's what gave birth to this project that we now know as OpenMRS. And check out this awesome initial logo that we created back in 2007. It was a beauty, huh? Actually, the truth of the matter is I built it with clip art, but it was a process. we had to crawl before we walked. And we decided at that time that really the goal, because everyone was doing their own thing independently, was really to coordinate a global community that could really basically work to support each other and create a public good, an open source platform, and a way in which to build medical record systems. And so we put some time into thinking about what principles and what values we committed ourselves to. And it was really about making sure that patients were always first, being really transparent about the work that we were doing, try to improve the world through a broad collaboration, and we would all learn as we went and make things more sophisticated over time. And what we ended up building collectively wasn't necessarily a shrink-wrapped application as much as it was a collection of Lego blocks. And we built over the course of a couple of years, and we started creating some standards around conventions around how record keeping could be done. This is an early version of the the OpenMRS data model. And then we started to build community. What was 4 or 5 of us became, dozens of us. And interestingly, over the years that grew, way beyond what I would have anticipated when we first made that trip back in 2004. So that community grew over time, and that allowed the software to become more sophisticated over time as well. We started thinking about, going from Lego blocks and retrospective data entry to point of care system where clinicians could directly interact with the medical record. Then we also saw lots of implementations. This was a screenshot of our atlas at one point in time back in, I think, 2011, 2012. We grew a lot of implementations all throughout the world, and it kind of just became this viral thing that really was, collective action manifest. And we started to develop what became the OpenMRS ecosystem, and that ecosystem had a lot of important people. But just to give you an idea of how these things form, Gabu Mendy was a clinician that was leading information systems work at this environment called the Institute for Human Virology in Nigeria. And he had the idea of scaling OpenMRS through his institute, which was about 60 or 70 settings at the time. But he realized that ultimately this is what Nigeria was going to need. And if you fast forward to today, Nigeria has made a national commitment towards using what became the Nigeria MRS, or the NMRS, and it's now implemented in over 2,500 settings throughout the country. And all of that work was done by Nigerians for Nigerians using the OpenMRS community and platform. Judy Wawira is another example of an implementer who showed us that OpenMRS had relevance in all kinds of settings, whether they're sophisticated settings or really emerging settings. And she worked in one of the poorest places I've ever been, the Kibera slum within downtown Nairobi, and worked within the Shining Hope Clinic, right in the epicenter, and provided a record system which to this day continues to thrive. And so we realized that the breadth of implementation sites actually was a part of the success of the platform. Then we started working with countries. And so Alvin Marcelo is another global health informatics professional who at the time was working with the Philippines Ministry of Health and advocated for an educational milieu around OpenMRS. They had universities had training courses and built a rapidly evolving ecosystem of implementation players that was sponsored by the university system there within Nigeria. And then you have people like Richard Kukuba, that as the countries become more mature and establish e-health leadership, that e-health leadership advocates for things like national standardization around a common medical record platform. And so the Rwandans actually developed a team of engineers that were trained specifically to implement open MRS at national scale, but sponsored by the Ministry of Health. All of this momentum continues to pour more and more sophistication into the platform. And to today, people have standardized on common ways of building the user interface through a widgetized model called micro front ends, for those of you who are technical. And you can see that it works cross-platform, whether it's a mobile application or a web browser, and the software continues to become more and more sophisticated over time. And the community continues to grow in ways that is breathtaking, to be quite honest with you. I spend most of my time hanging on for dear life, just doing what I can to support this rapidly growing community. This is what Open MRS is becoming. And I guess what I would say to all of you that are interested in being engaged in global health, now is probably a really special time in the space, that the work that you do, the ideas that you have, can have impact. And what I can maybe share from my little vantage point is that working in solidarity with countries alongside countries is a really powerful way to have an impact. And so I'm happy to take some questions and maybe share a little bit more in the Q&A, but just wanted to give an overview of the kind of work that I've been able to learn from over the past decade or two. Good talking to you all, and we'll get to the Q&A here in a second.